Dear colleagues, dear friends, it's my pleasure to animate this new webinar of the ENS field-based section dedicated today to the Retrosigmoid approach. We have a very nice panel of speakers this evening with new ones. You will see very interesting talks. The first speaker will be Stefan Lieber. You already listened to the talk of Stefan on the anatomy of the endoscopic endonasal approach. Now he will discuss the anatomical aspects through the Retrosigmoid approach. Normally, Sebastian Fröhlich will join us to discuss some technical aspects for the opening. Then we'll speak Pierre-Hugues Roche from Marseille about the closure techniques in order to avoid CSF leakage. We will have the chance to listen to Timothy Jackson on the interest of MR tractography. Then we'll have the chance to listen to Michel Calamarides working in Paris at the Salpêtrière Hospital in France about the vestibular schwannoma surgery with facial and auditory monitoring, and he will discuss the influence on the surgical procedure. Then we will listen to Marco Statagiba, as you know, from Tübingen, very experienced in vestibular schwannoma surgery, and he will discuss with us the surgical technique, the treatment philosophy he develops, and the result of his surgery. And we'll have the chance to have also with us this evening Massimiliano Visocci from Roma in Italy to discuss with us the microvascular decompression and its new trends and the new technologies. So I give the floor first to Stefan Lieber. Please, Stefan, we are listening to you about the anatomical aspects. Please, Stefan.
Thank you very much for having me. It's always a pleasure. Can you see this all right?
Yes.
Perfect. All right. So I'll be covering some of the anatomy of the retrosigmoid approach. And being the first speaker of this illustrious group, I just wanted to remind all of us that this, the first description of a unilateral suboccipital or retrosigmoid approach, as we know today, is essentially 120 years old already. First description by Feder Krause in Berlin. As we know from Cushing's description around the same time, this was still a bilateral decompression of the posterior fossa or access to the posterior fossa. And the next description, the beautifully illustrated series of Walter Dendy's slide data, is the first unilateral description which employs a lot of the techniques as we know today, with openings of the cistern, capsular dissection, drainage of CSF from the cisterns, or even from access to the ventricle. I will be briefly covering just some of the bone. We are talking mainly for this approach, we're talking about the asterion. We have the pterion here, the parietal squamous, and the parietal mastoid suture here. And this triangular suture, the asterion of the parietal mastoid and occipital mastoid and parieto occipital fissure is fusion is here this bony landmark which we are using. We have the supramaxillary mastoid crest, the squamous part, and the mastoid portion of the petrous bone. It's the asterion itself is not a reliable landmark for the genu of the transverse and sigmoid sinuses, but this is a nice depiction of this rough landmark. This is a left side, just a posterior projection here. We have the mastoid tip. We have the parieto mastoid suture here, the parieto occipital suture, and the occipital mastoid, you should say here, with the asterion and the verval just slightly infromedial to it, which exposes on the inside of this left side just the genu of the transverse and the sigmoid sinus here. This is the lambda suture. This is the occipital crest towards the occipital towards the foramen magnum, and the correlate here for the emissary vein, which can be seen on the external view also with the sigmoid sinus here. So again, occipital bone, parietal bone, and mastoid portion of the petrous bone or temporal bone. This is obviously not a retrosigmoid approach, but it's the extension of the retrosigmoid approach. We'll be covering some of the anatomy exposed in this specimen here. In later talks, we'll be having the extension, transcondylar extensions, transpetrous combined extensions, and of course the bilateral approach. This is just an illustration of the anatomy around the genu of the sinus in the posterior fossa, which we'll be covering in this talk. This is a skull-based talk, but some of the brain anatomy, just briefly, the emergence of the cranial nerves from the brainstem. We have 5 here in the vacuum pontis, the minor and the major portion. We have the olive here with the anterolateral and posterolateral sulcus. The decussation here of the pyramid. We have 6 emerging from the pontomedullary sulcus. 12 emerges anterior, so in the pre-olivary sulcus, or the anterolateral sulcus, and posterolateral sulcus is the 9, 10, and 11. And the lateral extension of the pontomedullary sulcus is the origin of 7 and 8 here in this ventral view of this brainstem. This is now a retrosigmoid perspective, or an extended retrosigmoid perspective of a right side in a specimen, which gives us the 7 and 8 complex, 9, 10, and 11, the cranial spinal rootlets of 11 ascending towards the jugular foramen, and then in more anterior 45-degree trajectory, you have the hypoglossal nerve here. Again, this is the olive. We have posterolateral and anterolateral emergence of the cranial nerves here. Some of the vasculature will be covered in a later slide. This is, again, not a strictly retrosigmoid perspective, but a more lateral perspective towards the anterior surface or the ventral surface of the brainstem. Again, you can see the olive, you can see choroid plexus, flocculus, brachium pontis with 5, even 4 here in the sesternal space, and 7 and 8. So essentially all the cranial nerves, 12 down here towards the vertebral artery. We'll be covering probably some of the vestibular schwannoma surgeries and aspects of extended approach, suprameatal drilling, inframeatal drilling of the jugular tubercle, probably also, and the discussion or potential discussion of venous sacrifice or venous injury to some of the draining veins, the most important one being the vein of Denyer, superior petrosal vein, which drains anterior, just superior or even inferior, so lateral to the internal acoustic meatus into the superior petrosal sinus, and is essentially the most important draining structure of the cerebellum and the anterolateral aspect of the brainstem. This is highly variable, so this is the draining area of Dendy's vein. And as we know from Matsushima's or Roton's classification, there's 4 draining groups, so the venous drainages can be organized in four groups. The Dendy's vein itself is not necessarily just one draining vein, it can be a complex of bundled veins. There's a lot of variation, but generally this is a useful classification for the venous drainage of the brainstem. The most important one being the vein of the cerebellopontine fissure, which drains the superior and ventral aspect, which is the main contributor to Dendy's vein. Then we have the anterior mesencephalic group, which is mostly the transverse pontine vein, which is this group of veins, which is sometimes, in rare cases, associated with the venous trigeminal neuralgia, venous compression syndromes. Then we have the pontotrigeminal vein, which is the ventral aspect, coursing here behind, the superior contribution to the Dendy complex, and then the tentorial contributions, the lateral contributions, which probably can be seen partially here in some other slides, but not in this isolated cerebellar and brainstem specimen. Just very briefly, but this is probably more familiar, just covering the arterial supply of the posterior fossa. This is a superior view, obviously not a surgical exposure, but an endotopical dissection with a very prominent basilar and vertebral artery here on the left side. This is the tip with the posterior cerebellar, posterior cerebral artery and the superior cerebellar artery with 3 traveling between. The perforatus, Pachon perforatus here in the interpendicular fossa, which has been cut out. Then we have a prominent ICA on the left side, a very dominant vertebral artery, and as we'll see in a later slide, a slightly hypoplastic vertebral artery and pica complex on the right side. This is the same specimen, just slightly inferior. Again, a very prominent vertebral artery here, hypoplastic vertebral artery on the right side. This is the pica complex, ICA complex, with the main contributors to labyrinthine artery and subacute artery, the arteries we will be discussing in relation to vestibular schwannoma surgery, and then the periphetus of the pons and the brainstem, again pontine perforatus here in the interpeduncular fossa. This is returning to this right-sided retrosigmoid view into the internal acoustic meatus and the jugular foramen. And there are some aspects we already discussed with this, some draining veins. Probably the Dandy vein itself is slightly superior in the specimen, and 5 nerves coursing into the internal canal. And there's this particular topography for this. There is a superior and inferior compartment, which is divided. I will be showing this in this next slide. So essentially, we are talking about 5 nerves: the cochlear nerve, the superior and inferior vestibular nerve, the small intermedius nerve, which is related mostly to the facial, and the well, essentially the 3 bundles of the vestibulocochlear nerve, intermedius, and facial nerve running supra-anteriorly. Then we have the nerves coursing into the jugular foramen, the glossopharyngeal nerve, 10th nerve, and again the ascending spinal and cervical fibers of the abducent, the accessory nerve. This is the typical distribution of these 5 nerves coursing into the internal acoustic canal. This is again a right side, inferior and superior. Exposure here of this posterior aspect of the petrous bone. Bill's bar and falciform crests are bony lamellae, which can be seen also on high resolution CT, which essentially divide the fundus into this aspect, with the facial and intermedius nerve running antero-superiorly, cochlear nerve antero-inferiorly, and the both division of the vestibular nerve more posteriorly from the retrosigmoid perspective. This is best understood only briefly because we're talking about posterior fossa, not directly about petrous bone anatomy, but only briefly to better understand this distribution within the petrous bone, and maybe also the bony protrusions that might be covered in suprameatal extension, inframeatal drilling, or drilling of the jugular tubercle from the retrosigmoid perspective. And we will be exposing the intrapetrous structures of this region here with the internal meatus canal in this open dissection, which is displaying here the vestibular system with the semicircular canal or canals. We have the cochlea, which is partially drilled, and we have the facial nerve, which runs anterior superiorly with the cysternal segment, labyrinthine, genu, and tegmen, tympanic segment, and here the descending sternomastoid segment. So this is essentially the cause of the facial nerve in the petrous bone, GSPN, giving off GSPN in the genicular portion here, and posteriorly we have the superior and inferior branches of the vestibular cochlear nerve. This is the intermedius, which runs with the facial nerve, and inferior to this we have the cochlear nerve, which connects with the cochlea. Just briefly touching on jugular foramen anatomy. Jugular foramen is a partially bony and partially dural compartment within this bony compartment formed by the petrous bone and the occipital bone. Again, the tympanic and the mastoid portion of the petrous bone. There is an intrajugular process which can be also defined for there's various compartments, but there is a main venous compartment, the sigmoid part, which is essentially the jugular bulb, the final turn of the sigmoid sinus, and then the anterior nervous compartment with essentially 9, 10, and 11. We have the venous contribution of the inferior petrosal sinus, which runs in the petro-occipital or petroclavial fissure. And this gives an interior, smaller interior venous compartment, the vein venous compartment posteriorly, and a small nervous compartment in the anterior aspect of the jugular foramen, or anterolateral aspect of the jugular foramen. Here in the condyle, you can see the hypoglossal canal, and this all correlates with this intradural anatomy of cranial nerves here below the tent of 3, 4, 5, 6, 7, 8, 9, 10, 11 in the jugular foramen, and hypoglossal nerve down here. Returning to the retrosigmoid perspective of the jugular foramen, in this case, we have 9, which is separated always by a small dural band. So this is the nervous compartment of the jugular foramen, but still there's a subsegment with a glossopharyngeal canal. So this is 9 glossopharyngeal nerve. We have 10 coursing here from the posterolateral sulcus, and then again the ascending fibers, cranial and spinal fibers for 11, and coursing anteriorly with the hypoglossal, towards the hypoglossal nerve, we have the fibers of the hypoglossal canal, which originate anterior to the olive from the anterior medial sulcus. This again is a more anterior view into the anterior aspect of the posterior fossa. So this is the pica tonsilla segment of the pica. We have vertebral artery and smaller arterial branches, often connecting, as we know from paragangliomas, with the external circulation, ascending pharyngeal, occipital artery, the arterial anastomosis via the jugular foramen. Again, we can see the olive, posterolateral and anteromedial sulcus of the medulla. And this final exposure just showing again an extended view, not so the inferior extension of this far lateral condylar exposure with the B3 segment of the vertebral artery, antedural segment of the artery. And I just wanted to show this to demonstrate that the nerves coursing into the jugular foramen always run medial and anterior to the jugular bulb, and are not at risk in this posterior exposure. This is the extracranial course of 9, 10, 11, and the hypoglossal canal fibers running. This is the ascending fibers. Hypoglossal canal obviously is exposed more anteriorly. This was just a brief review for this talk for this session with a lot of speakers. And as always, I wanted to thank my mentors, and not only in surgery, but also in microanatomy over the years. Mostly my current chairman, Sebastian Fröhlich here in Paris, and Juan Fernandez Miranda, and my dear friend Maxi Nunes, who is working in Stanford now, with whom I share a lot of pictures, some of his pictures also in this talk, and a lot of ideas. Thank you very much.
Thank you so much, Stefan. Very interesting overview, anatomical overview, and it's a perfect introduction before starting to the discussion on some technical aspect with an overview of the anatomy. Sebastian Fröhlich has to apologize. He cannot join us for his talk on some technical tips for the opening, but surely we will not blame Sebastian, since he's very active for the section. We will see him the next time. So we will go directly to the next speaker, who is Pierre-Hugues Roche from Marseille, who will discuss with us some technical points to avoid CSF leakage after a retrosigmoid approach. Please, Pierre-Hugues, up to you. Pierre-Hugues?
Can you hear me? Yes.
Yes, perfectly.
Okay, so what should I do to share my screen? Partager l'écran.
Please, the arrow.
Sorry for that. I hope it's coming very soon.
Yes,
Can you see my screen now?
Yes, not yet in full mode.
Okay, I'm gonna apply for a slideshow. Okay, dear colleagues, I'm happy to share this session with you. Once again, thanks to the energy of Michael Bruno, who is really a wonderful leader for our group. He's always stimulating us, and I applied very late, and I'm sorry for that. Anyway, I would like to share with you a few tips and a few words about the CSF leaks, because as you may know, even in experienced hands, we still have some. And I will go through some details with you during this very short and compact presentation. First of all of us, we know that the retrosig approach, as all the skull-based approaches, carries risk, and this risk are mainly due to the target that is approach, which means that when you are managing an acoustic schwannoma or meningioma or epidermoid cyst, the fact that you manage each kind of this disease carries its own risk, and you can see here on this slide from Cohen-Gadol that the complications which are honestly displayed here indicates a lot of potential complications, which are mostly linked to the management of the target by itself more than by the approach properly. But you can see that depending on the approach, you have difference between the risk, and that's funny to see that the potential risk for CSF leaks is different according to the approach, coming from a middle fossa to the retrosig or translab. You can see that in the hands of this group, this was, by the way, an analysis of the literature. They found that they had more CSF leaks with the retrosig approach instead of the translab or the middle cranial fossa, which is questionable, because I'm not sure that these data are overlap the experience of all of us. Anyway, announcing that there is a 10% of CSF leaks through the retrosig approach is probably the good way to address, because in my hands, and we always think that we have a few complications, but in my hands, we operate in our group more than 600 retrosig patients, and still we have some, and 10% is not far from our experience. Probably Marcos will discuss about that, but 10% seems to be a good, on average, a good number. Okay, we are addressing the issue not of the target but of the approach. And when exposing the disease through the retrosig, it means that you will have to open the bone, of course, to open the dura, and probably somehow to drill the mastoid, some part of the mastoid, and in some cases, probably much more for acoustic schwannomas than for meningiomas, we will have to drill the meatus, and in this place there are some air cells that can be exposed. So this exposure of the dura, of the cisterna, of the CSF, and of the air cells carries some risk of CSF fistula, and we can classify these fistulas in two different categories. The first one is incisional fistula, then the second one is rhinorrhea. And the way we have to manage these two kinds of CSF leaks is in my view very different. Okay, about the frequency of the CSF leaks, I already told you in the previous slides the figures of all these authors, and you can see that some hopefully have zero, and some of them have a lot. And anyway, we will have, if you already did not have any, you will have some, and you have to be prepared to have some to prevent that and to manage if it happens. About the risk factors, it's very difficult to associate the risk of CSF fistula with preoperative and perioperative risk. The group from Magistani more than 10 years ago published a paper in the DNS, and in their experience, they considered that redo surgery was a risk factor for CSF fistula, and they probably had a tendency that previous radiosurgery would carry some risk, but they could not demonstrate that from a statistical point of view. I personally operated more than 20 failed gamma, and I do not consider that this is a potential risk for fistula, because gamma is not a radiation technique like others, and usually it doesn't give any scar on the dura and on the soft tissue. So I'm wondering whether this is a potential risk. In my hands, not, but we can discuss about that. Okay, this paper is very interesting because this was published 5 or 6 years ago about the Mayo Clinic group with Michael Link, with a huge experience of acoustic. And they focused about 3 interesting parameters. The BMI, you may know that in the US, unfortunately, they have a lot of overweight patients, which is an issue when we operate skull-based tumors, of course. And they could show some statistical significance about the BMI of the patient and the risk of fistula. Again, they could show that the increase of the operative time increased the risk of the fistula, and they showed that the translab approach, which is not exactly the purpose of our talks, was positively associated with an increased rate of CSF fistula. I used to operate a lot of patients with a translab. I do not do anymore because it's a demanding approach. But in my old experience of this approach, we used such a huge amount of fat that I did not have the feeling that we had more fistula than with the Retrosig approach. So BMI is probably an interesting point to consider. Anyway, in my experience about, once again, hundreds of patients operate with Retrosig, I did not find it as a significant predictor of fistula. To be honest, the more significant predictor I found, even so I did not statistically study that, was the exposure, of course, of the mastoid. In case of patients with usually pneumatized mastoid, the fact that you have to skeletonize the sigmoid sinus and to expose huge air cells, even though you take a lot of time to bone wax, to close, in this case, I had significantly more patients with post-op CSF fistula. And this is the only significant parameters from my view. It's a little bit intuitive, it's not demonstrated, but exposure of big amount of air cells influence significantly the risk of fistulas in my own group, in my own experience. So how to manage? This is very clear. In my opinion, incisional CSF fistulas are as a rule, relatively easy to manage. Usually, we propose to the patient 3 lumbar puncture, and for each of them, with a big needle, we withdraw more than 30 cc each. And of course, we recommend a mastoid pressure dressing. And in this case, the majority of them are managed with this very simple way to do. In case it doesn't work, we go for lumbar drainage during 5 days, and of course, a mastoid pressure dressing. And to be honest, as far as I can remember, I did not have to open again and to reoperate and to offer a revision surgery in this case, because it always works. If it doesn't work, it probably means that the pressure of the CSF is too high, and it means that probably you will have to offer or to consider a shunt for this kind of patients. So the management of this one are very clear. Unfortunately, we could see in one case this kind of patient who was operated twice in another center with a CSF oozing from the scar, and you see this kind of defect in this case, but you have some foreign body inside. You have titanium plates in the head, and probably some infections under the skin, which explain the defect. And in this case, it's very complex to operate this patient. You have, of course, to remove all the foreign body, and probably in some cases, and we published that years ago, you need the help of a plastic surgeons to offer the patient this kind of vascularized flap. If you don't do that, it will be very difficult to manage. This is really exceptional situation, and you can see at the end that the results it's quite acceptable. The other issue is about the rhinorrhea. Rhinorrhea is probably much more difficult to manage, because in this case it's usually useless to propose lumbar puncture. It's useless. Even if you offer Diamox to the patients, acetazolamide plus the lumbar puncture, usually it doesn't work. We did that in the past. Nowadays, we go straight ahead to the lumbar drainage during 5 days. The patient keep bedridden, and we can control the CSF rate of drainage. And in this case, usually, not usually, but in 50% of case, it's enough. But in 50% of case, it doesn't work, and you need to go for a revision surgery. Why? You can see in this bone window CT scan that the opening of the air cells here at the level of the mastoid is high. There is a big hole. You have a leak and the communication with the mastoid and the eustachian tube. And in this case, you need, this is very simple, to plug the hole with fat. This is the only advice I could show you. You remove the bone flap, you harvest the fat from the abdominal fat, a big amount of that, and you can plug that. Of course, we use fibrin glue with that, but usually harvesting enough fat and plugging the hole in the mastoid with this is usually enough to manage this issue. Okay, so how to prevent? Prevention starts with the opening, of course. Clear cut of the dura mater is the key. You keep it humid during the surgery because otherwise you have the retraction due to the light of the microscope. And usually I stitch back with a running suture more than this kind of differentiated stitches here. Usually I close with a running suture here. You have to do that watertight. Of course, it's not enough. You have to plug systematically with bone wax the mastoid. Even so, you do not see any opening of any air cell. You have to plug systematically with bone wax. And usually the technique is to offer a kind of sandwich technique, which means that I usually plug with bone wax. Then I put the bone dust that I kept during my burr hole, and I mix this bone dust with some T-seal, and then I put back the bone flap. And as much as possible, you have to push the bone flap against the mastoid to plug everything. So this is my way to try to prevent this kind of CSF rhinorrhea. So at the conclusion, it should never be overlooked. I remember a case, and I will end up with that, of a patient coming from North Africa. She was a 41-year-old with a big acoustic. We operate this patient in Marseille. She remained during 2 weeks in Marseille at the vicinity of the hospital. She was quite okay, and without any additional leak, she went back to her home village in a remote place in North Africa. And we heard 2 months later on that the patient experienced some CSF leak. She experienced some meningitis and she died about that. So you should never overlook this kind of complication. It's not so easy to prevent. Even so, we are experienced neurosurgeons, and we have, all of us, we have our different methods to do that. Anyway, it requires a meticulous opening, meticulous closure, and each of us, we have different protocol to manage when it happens. Okay, that's all. I thank you.
Thank you, Pierre. Very relevant to focus on this very important aspect. And indeed, you spend so much time to resect a vestibular schwannoma. If you have a complication on the approach, it will be a pity, and we should focus on this point, which is very important. So it's now time to move to Lyon. We remain in France. And to give the floor to Timothy Jackson, who will discuss with us the place of DTI in vestibular schwannoma surgery. Please, Timothy. We cannot listen to you. You are mute.
Is it okay for you?
Yes, it's perfect.
Yeah.
Please.
I will just share my screen. I had connectivity issues, so I was late, so I'm sorry for that. But now it's all right, and I just want to take a few minutes to thank Stefan, because the pictures were amazing, and I spent times in Pittsburgh too with Juan Fernandez Miranda, and it was a great time. So I can see and can recognize the style, the roton style on these pictures. So it's very a pleasure to see this kind of picture. So I try to share my screen, but do you see my screen right now?
Not yet.
Not yet. Okay. Okay. Just go back to Zoom.
And
Yeah.
indeed, I confirm it's a fantastic job of Stefan. It truly have taken so many hours to obtain such pictures.
Sure.
Congrats, Stefan.
Okay. Yes, I'm here. So I think that's good right now.
Yes,
Yeah.
not yet in full mode, but
yeah. Are we good?
That's it. Perfect.
Okay, thank you very much. Thank you, Michael. Thank you for everyone to allow me to do this presentation and to share my experience. Do you hear me well? It's all right for the sound, right?
Everything is perfect.
Okay. So thank you very much. I just wanted to give you an insight of what we can do with tractography to improve the surgery or the preoperative planning for such a retrosigmoid approach. So the beginning of my talk will be about just a quick reminder of surgical anatomy, but I don't want you to go more far than Stefan, because these pictures were also amazing. I will give you some principle about MR diffusion tractography, and then I will explain two types of tractography. The first will be a region of interest based fiber tracking, and the second will be a full tractography. So I just wanted to give you this summary first. I won't take too much time for the retrosig approach, but just to say it's one of the most popular approach for the skull-based tumors. And the important point is, we'll use a pointer, yeah. We will cross some cranial nerves of the skull base, and we will cross a lot of cranial nerves, like the fifth, the acoustic fascial bundle, and the lower nerves, maybe the 12th. And it's very important to remind the position, the orientation of each nerve to anticipate the traps for any skull-based surgery. So when we do the retrosig approach, we cross this area, we open this piece of bone just behind the sigmoid sinus, right? And then that's important to remind that we will be in the narrow space, crossing a lot of cranial nerves in the posterior canal fossa. You can see in this undercranial view of the temporal bone, this groove, which is the bone for the superior petrous sinus, and then see the level of the internal acoustic meatus, which is quite high if you see the whole petrous pyramid. That's an important point to remind. And another point is the level of the jugular foramen there. And it's just an insight, a recall of the position of cranial nerves in the posterior cranial fossa. So the retrosig approach would be there, just below the level of the asterion, behind the base of the mastoid process, to be exactly at the edges of the lateral and sigmoid parts of the transverse sinus, right? And that's very important if you consider to do retrosig approach, to be exactly at the edges of the sigmoid and the lateral sinus. And you can find this level using the navigation system, but also using anatomical landmarks. If you can feel the beginning of the zygomatic process, you can also feel the inion, and you draw a line between these two landmarks, and you will be exactly above the sinus. And most of the time, just anterior to the asterion, you can feel a bone depression, which is exactly posterior to the mastoid process, because at this level specifically, the bone will be just a little bit inferior, and you can feel a bone depression because of the bump of the mastoid process there. So this little bone depression would be exactly the level where you can do your first burr hole for the retrosig craniotomy. So this is the patient positioning. You can see the asterion, and you can see that you can start your drawing or your first burr hole just a little bit inferior and anterior to the asterion, posterior to the base of the mastoid process, and interior to the line drawn by the zygomatic process and the inion. So it's just a few remarks of the few comments of the surgical anatomy. So I like this one because it's the anatomy already presented a few minutes before, but it's in the operative view, in the operative assay. So you can see on the right side, up is on the left, down on the right, and you can see the trigeminal nerve, and then the acoustic fascial bundle, the 9, the 10th, the 11 with its 2 branches. And in the deepness, you can see the 6th nerve, the abducens one. So it's good to remind all of this disposition of the cranial nerves when you do the retrosig approach, and remind that this orientation of the cranial nerves will be a little bit different, because the trigeminal nerve will go posterior anterior, quite straightforward, while the acoustic fascial bundle and the lower nerve will be like more medial lateral, quite perpendicular to the trigeminal trajectory. So it's important to remind this point specifically. You can see this little structure there, which are the choroid plexuses, exactly anterior at the level of the Luschka foramen, and this is the flocculus. So if you look at the cerebellum lamella there, and you can see the flocculus, and the acoustic fascial bundle will be just anterior to the flocculus and above the level of the choroid plexuses. So it's important to remind these points. If you search your acoustic fascial bundle, you just need to identify the flocculus, and it will be easy to identify the acoustic fascial bundle. And if you want to stimulate the facial nerve, you have to remind that the facial nerve will be superior and anterior, considering the acoustic fascial bundle, but there is a little subtlety that the acoustic fascial bundle, the acoustic fascial nerve, the facial nerve will turn around the acoustic fascial bundle. At the level close to the brainstem, the facial nerve will be inferior, and then it turns around behind the acoustic fascial bundle to become superior at the proximity of the porus. That's a very important point. I just want to make this comment for the younger neurosurgeons that can watch this video, right? So some comments about the MR diffusion tractography. The MRI is able to detect the orientation of the diffusion of water molecules along white fibers in the brain. At the first point, you can see diffusion, which has a Brownian movement in the all direction. If you consider this cup of water, this box of water, but along the fibers, the white fibers in the brain, the orientation or the diffusion of water molecules is constrained along the trajectory of white fibers. So that's very important to remind this point, and for understanding the tractography. And there are after that the different mathematical algorithms that you can apply to reconstruct the trajectory of the white fibers. First point, and more the tractography is evolving, because it was developed at the beginning of the 21st century, in the thousands years, and at the beginning it was all about DTI, which is the tractography based on the diffusion tensor, and the diffusion tensor is able only to detect or to depict one orientation of white matter fibers. And then the diffusion model is changing little by little, and now we use more the ODF, which is a mathematical, which is a view, an insight of the probability of diffusion along different direction, and it's the best model diffusion because it's able to depict more than one direction of the diffusion of water molecule within the brain. So that's quite complex, but it's very important to understand this, the history of the tractography, to understand how to do it in the clinical practice. So the tractography is not only one step, but it's a multiple step pipeline, from the MRI acquisition, then ROI design, tracking process using the mathematical algorithm, then filtering of ground truth control, then the visualization, and then the validation during surgery if possible. So how we do that? Yeah, I will talk about that just a few minutes after. The thing is, if you look at the MRI, like high resolution T2 MRI, you can identify most of cranial nerves actually. On these T2 pictures of the axial slice of the MRI, you can identify the optic nerves very easily. But the same for the oculomotor nerves, the trigeminal nerves, the acoustic facial bundles, the lower nerve, and the hypoglossal nerves. But the problem is, in case of skull-based tumors, if you look at these pictures, on the healthy side, it's easy to see the trajectory of the acoustic facial bundle. But on the tumor side, it's not easy. And most of the time, you can't identify properly the trajectory of cranial nerves which are displaced or stretched around the tumor volume. So that's a big issue. You can identify a trigeminal nerve on the healthy side, but on the tumor side, it's not easy. That's why we used, firstly, a region of interest-based tracking. The principle is to apply on a T2 map an ODF map that gives you a merge map with ODF signals superimposed on T2 map. You can zoom a little bit, and you will identify the best balance between the ODF, which are the, I just want to recall that, it's an insight of the probability of the diffusion of water molecules along the white fibers in the brain. So these pictures, these models, these symbols can be superimposed on the classical T2 map. And if you find the best balance between the T2 and the ODF, you can follow the cranial nerves. And then you can put some region of interest, and you can apply a mathematical algorithm. It gives you this kind of pictures. And then you can follow, in our experience, most cranial nerves, maybe at the, except the fourth, which is very, very thin, it's possible for all other cranial nerves. So on this specific example that we just previously seen, we were able to identify the trajectory of the facial nerve at the anterior pole of this vestibular tranoma. And the other example was a petroclival meningioma. And it was very hard to identify where the trigeminal nerve where this was displaced. And I just wanted to show you a sagittal view of this. On a sagittal view, it's more easy to understand that the trigeminal nerve is pushed inferiorly at the peripheral area of this petroclival meningioma. And we use this technique during the first years of our experience in tractography. I just wanted to show you this example of a big arachnoid cyst, and we applied this ROI-based tracking, and we tried to identify the way the cranial nerves were pushed away or were located in this specific environment of the tumor of this cyst. Sometimes it's hard to identify them, but you can move the 3D rendering of cranial nerve tractography to try to mimic the retrosig approach and the retrosig surgical view at the beginning of the approach. And we were able to do that. And we were able to anticipate the way the trigeminal nerve was pushed superiorly and anteriorly, and it was it gave us some confidence at the beginning of the surgery to identify the cranial nerves very early and to move fast during the surgery with a more safe and accurate surgical removal or opening of this arachnoid cyst. So that's the way we first used this ROI-based tractography. But from time to time, we realized that it was quite hard to apply it in the clinical routine because it required a lot of steps from the acquisition, the post-treatment, the algorithm, the definition, the design of the region of interest. So we try to think differently and to say, okay, we need to reduce, to limit at maximum the steps that will be dependent of the user. So why not trying to avoid the region of interest and designing like a big region of interest at the pictures in B, and then we negated the region of interest to create this unique region, and then we apply the tractography in this whole volume, including the tumor, the brainstem, the cerebellum, and the cranial nerves trajectory, the systems of the skull base. And we get this result with a specific color code. In green, you have fibers coming anterior to posterior or posterior to anterior. In red, these are fibers that crossing medial to lateral or lateral medial. And in blue, fibers that and go up to down, down to up. And as you can see, this kind of full tractography was quite accurate, and it was able to depict very precisely the different trajectories of cranial nerves. V1, V2 is cut there, V3 is diving inferiorly, the lower nerves of acoustic facial bundle. So it was quite accurate actually, and that's the direction in which we are moving right now. I give an insight of our new full brainstem tractography approach. Yeah, I could just switch off the sound. Having adjusted a region of interest that included a brainstem. So unique region of interest. This ROI was negated to create a unique region of avoidance. Then, a full tractography was initiated using a quantitative anisotropy-based deterministic algorithm. So that's very simple. After slide filtering, very easy, three-dimensional rendering in and very fast. Software allows rotation and magnification on demand. The following cranial nerves were identified: optic nerves, the third, the fifth, the sixth, the lower nerve, and the acoustic facial bundle. Some of them were tracked not only in their systemic trajectory, but also in their cavernous and orbital segments. The brainstem compression was well seen. This full tractography rendering led to a better understanding of each paper. So that was this kind of insight I wanted to show you. And it was a vestibular schwannomas and not very appropriate for retrosig purpose, but that's what I this this second case. I do it for every complex skull-based tumor, but in this case, it was a little bit more obvious, but I did exactly the same post-treatment. You're supposed to take 15 minutes maximum. It's supposed to avoid any user-related or user-dependent step. And at the end, we hope it will provide an insight of the anatomical environment of the tumor, the way the tumor pushed the brainstem, and the way the tumor displaced the cranial nerves around. So on this picture, you can see that the trigeminal nerve pushed superiorly and laterally to the tumor. It was a big meningioma of the inferior petrosalpinx, inferior petrocleval area. So it's just an example that how we can use the tractography in the clinical practice, and we work very hardly to make it feasible in the daily practice, because from the beginning the tractography is like a tool for for computer guys, and we work very hardly to make it usable for any neurosurgeon. We want to do thorough preoperative planning, and for any neurosurgeon who want to anticipate the position of cranial nerve displaced around this kind of skull-based tumors. So yeah, we try to apply the same pipeline of full tractography for a case from the Human Connectome Project database, just to show that it's possible to do the same pipeline for any kind of DTI data you can get. So that's it. I thank you very much for your attention, and I hope you will have interest in this tool, and I can give you a different insight and different advice if you want to try to use it in your practice. So thank you very much.
Thank you so much, Timothy, for sharing with us your experience and this fantastic tool. In line, in fact, with the talk of Pierre-Hugues, in order to decrease the postoperative morbidity by improving the preoperative planning. So it's for me a good way to make the transition with the next speaker, who is Professor Calamarides. Can you start to share your screen, maybe, Timothy?
Yes, of course.
Thank you so much, Michel, to be with us this evening. It's the first time that you join us. It's truly a pleasure for me to welcome you. You are working in La Pitié-Salpêtrière in Paris, and I have the chance to see how you master the retrosigmoid approach and the way to treat vestibular schwannomas. And you will also detail with us this evening how the management of the electrophysiology, the facial nerve monitoring, and the auditory monitoring will influence your surgery, also to decrease the postoperative morbidity. So please, up to you, Michel.
Thank you, Michael, for your invitation. I'm very pleased to be there with you. I will discuss about schwannoma. Just a few words about our current philosophy in vestibular schwannoma surgery, because it's very important. It will explain what we are doing. Now our team is treating only the large schwannoma by surgery, and all the small and medium progressive lesions are treated by radiosurgery. So it's very important to understand the natural history of the small tumor to decide the treatment and tailor the treatment. The second philosophy, I would say, it's that functional result, it's more important than the quality of resection. And over the years, with Olivier Serkers, we changed our mind for vestibular schwannoma surgery. And it's clear that the functional price to be paid for a total removal is too high. And what we want now is to avoid facial palsy. And the last, based on the experience, for example, in Marseille, we monitor the possible remnants and treat only in case of growth. But I think that one point is very important to evaluate and define what is the quality of tumor resection. It's not clear in the literature. So in my talk, I will define gross total resection as no tumor according to the surgeon and confirmed by MRI. Near total resection is when you leave a small piece of tumor and you see nothing on MRI. For us, it's not a gross total resection. And then there is a subtotal resection when you leave a small tumor and you can see on MRI a small piece of tumor less than 0.5 centimeter cube, and more than this volume, it's a partial resection. Mostly it's decided before surgery. And you see in this example on the right, this is MRI performed today, the day after surgery. It was a near total resection. You can see no gadolinium enhancement, and we did another MRI 1 month later, and you see a linear gadolinium enhancement. So the timing of the post-op MRI is very important. Do immediately or a few months later, not at 1 month. Okay. So during surgery, you know that there are some different course of the facial nerve. We define 3 based on the Jackler work, and this is the most difficult trajectory when the facial is very high, close to the 5th nerve. And we published this paper 3 years ago in GNS to show that the intraoperative monitoring of the facial nerve is used to guide the quality of the resection. It's not used to see where is the facial nerve. We know, so at the beginning, maybe yes, but we use this to help to decide when to stop resection. And to do this, we, in this paper, we analyzed 25 patients with not a gross total resection, and we stimulate the facial nerve at the brainstem at the beginning of the surgery as high intensity at 2 milliampere, and we continue the resection until a loss of 50% of the response at 2 milliampere. And with this strategy, we obtain a nice, good postoperative facial function, 1 and 2 Außen-Brackmann, in 84% of the patient. Then it's in this new series of patients with surgery during 1 year for large sporadic vestibular schwannoma, we decide to use the supramaximal stimulation at 2 milliampere, and we decide to stop the resection when we obtain a decrease in 40%. So you have to stimulate regularly at the brainstem at 2 milliampere just to evaluate the results and the amplitude. And when you have a loss more than 40%, you have to stop. And with this strategy, we obtain a good result at 1 year in 95%. And you see the quality of the resection. We obtain, I will go back now, I will go this. We obtain a nice resection in a lot of cases, more than 80%. You see the postoperative Außen-Brackmann function in this series, and you see there is some worsening of the facial at day 8, but you see it's 95% at 1 year. And this is how we are thinking now when we do vestibular schwannoma resection. We expose the facial nerve at the brainstem, so it's easier through a translab approach. Sometimes for the retrosigmoid, it's more difficult because you don't want to push the 8th nerve and the facial nerve. And then you do a first measurement of the supramaximal at 2 milliampere. It's a baseline. Then you will see the adhesion of the facial nerve, and you go to monitor regularly the response. And when you have a decrease more than 40%, and today it's 30%, then you stop the resection. It means you stop the resection between the facial nerve and the tumor. So you can remove the tumor, but you don't touch anymore to the facial nerve. So just to summarize the facial nerve dissection, we using the monitoring to guide. Now we stop the resection if the intraoperative supramaximal response decreased by more than 30%. We have 2 other elements just to be more cautious. When at 2 milliampere you have a bad response, less than 1000, it means that the facial nerve is stretched by the tumor, and you have to be very careful. And then, for sure, when during the surgery you see a strong adhesion between the tumor and the facial nerve at the end of the resection, even if the response is very good, sometimes you leave a small part. So it's a way to have a good postoperative facial function, even in the large. The challenge, hearing preservation for large vestibular schwannoma. A few years ago, I started the vestibular schwannoma surgery 25 years ago. Now I've done more than 1,500 tumors, but at the beginning, every large schwannoma was removed by a translabyrinthine approach. And with Olivier Sterker, a few years ago, we changed our mind because we observed that it was okay for the facial nerve even through a retrosigmoid approach. And we decided to try to preserve in the large vestibular schwannoma hearing. This is an interesting new paper published last month by the Mayo Clinic team, analyzing their results for hearing preservation for large vestibular schwannoma. And you can see that for tumor larger than 15 millimeter in the CP angle, using a retrosigmoid approach, they have only 10% of hearing preservation. And when the tumor is larger than 25%, it's only 6%. So for them, hearing preservation for very large schwannoma, it's maybe a dream, and it's not. It's difficult to realize this challenge. So, how can you monitor hearing during vestibular schwannoma surgery? You have the ABR, and we published this paper last year showing that in fact, yes, it's interesting to monitor ABR, but it's rare to have synchronized ABR for very large phenomena. And we think that what is interesting with ABR, it's more interesting as a positive predictor factor. So when you have a synchronized ABR, you have a 5 times greater chance of preserved hearing compared to the cases with desynchronized ABR. So in our series, we preserve hearing in 46% of patients with synchronized ABR. So in this series, it was a large and medium-sized tumor, but when ABR was not present, it was rare to preserve hearing. The next step is to use the cochlear nerve auditory potential to monitor. What is this technique? In fact, you put this ball on the nerve and you will monitor the wave 2 of ABR with a large signal. So you have an acquisition every 4 seconds, because for ABR, it's every 30 seconds. So it's very difficult to stop a surgery using ABR monitoring. You don't know what you are doing with the cochlear nerve, but with the CNAP, every 4 seconds, you have a signal, and you can stop the surgery. So you need to see the cochlear nerve, and it's difficult to stabilize this small ball. And when you have loss of the amplitude more than 40%, you have to stop. So now I modify the strategy compared to the translabyrinthine resection. So this is a case of vestibular schwannoma, and I start by monitoring the 8th nerve by the CNAP. So sometimes it's very difficult to see the 8th nerve at the bottom of the tumor. So I monitor like for the facial, and you can get some response sometimes. So you can see or imagine where is the cochlear nerve. Then I remove all the superior part of the tumor. And finally, using a dynamic monitoring, so you can move the ball, and you can then try to remove the tumor from the cochlear nerve using the CNAP. And when you have a loss of signal, you have to stop. And then you put here to remove this. And when you drill at the end, you can put the ball here, and then you can monitor, because the patient has a microphone. So you record the signal from the cochlea to the ball. So this is a small series of 37 cases. You see it's a medium size of the tumor, goes for in 84%, 82%. In this series of post-operative facial nerve function was 95, always using our strategy of guidance by the facial monitoring. You see the quality of resection in this series. So you see near total, subtotal, also normal MRI in 76% of cases. And we were able to get a CNAP signal as a brainstem in half of the patient, because at the beginning you need to remove the tumor. So maybe you can damage the cochlear nerve, maybe the CSF, the opening of the cisterna with CSF leakage is not good for the cochlear nerve, we don't know. And then we were able to monitor during the removal of the vestibular schwannoma. And you see when the CNAP technique was present, we were able to get a better results for hearing preservation. And sometimes we had to stop the resection because the loss of amplitude. And then in this case, you can preserve hearing like for the facial nerve. So we had some case of hearing preservation because the CNAP monitoring say, okay, you have to stop. And what is very interesting, I'm learning when I lose hearing during surgery. And now I'm like for the facial nerve, you can learn and you have a learning curve with the cochlear nerve. So you can lose hearing in the APC or during the drilling or at the dissection in the meatus. So it's very interesting. And the last, I'm sure that we have a lot of microvascular damage. And sometimes you are not doing nothing, you are doing nothing on the cochlear nerve and you are suddenly losing the knap. I think it's vascular. And we are using papaverine. And at the end of the resection, if you have no knap at the fundus and at the brainstem, it means that the cochlear nerve is totally destroyed and it's vascular. In contrast, if you have a signal at the fundus but not at the brainstem, it means that something happened on the nerve during the dissection. So it doesn't help to preserve, but you can make a diagnosis of the loss of hearing, and it helps a lot of. So just for the retrosigmoid approach, just with monitoring, you see at the beginning, this is probably the 8th nerve. You can put this ball and you have a signal. And then you can leave the ball and you remove the superior part of the tumor, as Marco Tattagiba will show. It's classical, so you can go very quickly. There is no 8, no 7 nerve. And then you can decrease. You see here the facial nerve as this part. This is a facial. You can see this is trigeminal. And then you can continue to remove the tumor from the facial nerve. And then we put the ball on the 8, just because now we will drill the porus. So when you drill the porus and when you remove the last part, you will have control of the 8th nerve. And you see, you can cut. So this part is done by the ENT. So I'm doing a lot of surgery now with Daniele Bernadeschi. So it's a teamwork. And you see, this is facial, this is the 8th nerve. So an example of a tumor, it's not a large one. And it was a subtotal resection. We had to stop 3 times during surgery. It was 30 seconds each time. And we preserve hearing. It's before, after, and there is a stable residual. You see the residual, and you see this is when you put again. It's like this. So in conclusion, I think that facial monitoring and hearing monitoring, it's a teamwork with ENT. So I'm doing all the surgery with the ENT. Before it was with Olivier Sterkers, now it's with Daniele Bernadeschi and Yann Nguyen. I think that we can say that the facial nerve function preservation is acquired, but it's sometimes very difficult. And there are some additional challenges for hearing preservation for the very large vestibular schwannoma. There is a learning curve. I think vascularization, papaverine. We have the difficulty of the lack of response initially when we see the cochlear nerve, maybe it's too late. So for the knap monitoring, maybe it's too late. What is difficult for the hearing preservation, we need a neurophysiologist in the room, because for facial nerve, we can monitor by ourselves, but for the hearing, you need someone to say stop. And now we want to select the patient based on hearing and ABR, not on tumor volume. So we have a new series in progress with 70 large vestibular schwannoma operated on using knap, but for such tumor, we are still using translab approach. I don't know how to remove and preserve hearing for such big vestibular schwannoma. Thank you.
Thank you so much, Michel, for sharing with us your experience and the way you deal with auditory and facial nerve monitoring to influence your surgery and finally decrease the morbidity. Thank you. So now we will move to listen to the talk of Marcos Tatagiba. I think it's not necessary to present who is Marcos. He already participated to so many webinars with us, and he's mastering also the retrosigmoid approach and the treatment, the surgical treatment of vestibular schwannoma. So Marcos, please, up to you.
Thank you very much, Michael, for the kind invitation and to have the opportunity to participate in this fantastic webinar. I would like to congratulate the previous speakers for the fantastic lectures they gave to us. And I would like to contribute with our experience using the retrosigmoid approach to different type of vestibular schwannomas, showing some technical details as we used to do in Tübingen. So everybody who is dealing with these lesions know that we are going to deal with a different kind of tumors, although all of them are schwannomas. And you see vestibular schwannomas may appear completely different, and we have to decide differently in each case. In the past, we adapted the approach to the patient and to the size of the tumor. But nowadays, we use in basically all cases retrosigmoid approach. Our philosophy is to use radiosurgery, particularly in those cases of elderly patients with small tumors which are growing. So if the tumor is not growing, we don't do anything. And if the patient is very young, we don't send the patients to radiosurgery. So in young patients, we go for surgery in order to cure the disease. And in small tumors, we have an excellent chance for facial nerve preservation and even a good chance for hearing preservation. And in our experience doing follow-up of 10 years in such cases, we have seen that in most cases, hearing will be stable over the years, different than radiosurgery, in which hearing will deteriorate over the years. So surgical indications in our department are those ones: large tumors with brainstem compression, cystic tumors, young patients. If the main complaint is really vestibular related, then we perform a vestibular neurectomy. And have two patients we use to decompress the tumor and keeping the function of facial and hearing if it's possible. And of course, patients' individual decision has to be respected. The goals are, of course, cure if it's possible, or at least stabilization of the disease, while we are preserving quality of life. As I said, in the past, we used to adapt the approach to the tumor. Nowadays, we have seen that all these cases can be very well approached via the retrosigmoid approach. And that's the reason I prefer to keep on this approach, to stay there, and to teach my residents to do like this. So this is the experience we have accumulated in Tübingen in the last 16 years, or in all cases using retrosigmoid approaches. Regarding electrophysiology, where for facial nerve, we use the stimulation, of course, during surgery, but also motor evoked potentials. And these, particularly the motor evoked potentials, are important in large tumors. As long as the MEPs are excellent, so we are satisfied and we are not worried that we have damaged the facial nerve, even if the visualization is not very well in large tumors. In particular cases, we can perform a free running stimulation of the facial nerve. If particularly in sitting position, if the patient has air accumulated between the subdural space and the skull, we may have deterioration of MEP because of the air accumulation, so that this direct stimulation will be very useful. And in particular cases of bad auditory evoked potentials, but still with hearing function, we used to put the recordings directly on the cochlear nerve in order to get better waves. I used to say that the retrosigmoid approach is actually the pteronal approach for the posterior fossa. It must be learned by all residents. It's extremely useful and important approach, and it's good to learn, and it's not difficult to teach. So, and the correct retrosigmoid approach, in my opinion, is that one which is showing just the border of this transverse sinus, just the border of the sigmoid sinus. We go down up the point that skull base is completely horizontal, leaving no parts of the bone hindering the access to the posterior fossa. And in order to avoid CSF leakage on the wound, we used to open the dura mater with a single incision along to the transverse and the sigmoid sinus. So I don't do additional cuts. I don't do flap of the dura, just a single incision. It will make the suture later on easier. We have listened to the lecture of Dr. Lieber showing the beautiful anatomy of the cerebellopontine angle. Of course, if we have a tumor here, this anatomy will be changed. Depending on the size of the tumor, we put the patient in supine or semi-sitting position. Why? In large tumors, using the semi-sitting position, we have seen that surgery is faster in semi-sitting position. So you see here, all of these cases are T4 tumor. Average time, skin to skin, to remove this tumor was 4 hours, going from 2 to 6 hours in average. Semi-sitting position, we have seen the quality of life, quality of surgery is better. So we could achieve a higher tumor resection in using the semi-sitting position in comparison to supine position. And we have seen that that facial nerve preservation in semi-sitting position, both immediately after surgery and later on, was better. And the contraindications or the collateral problems related to semi-sitting position are really should not be overestimated. This is, we have done here this study in more than 800 patients with semi-sitting position for different causes. And you see in no single case we had hemodynamic instability. A problem was in 3% of the patients. That means 3 patients in 100 had air accumulation at the subdural space that had to be removed with a saline solution. We make a puncture of the subdural space, and we exchange R exchange R and air and saline solution. So this is the only point. Otherwise, no really problem related with air embolism. So the surgical technique was the craniotomy, dura incision like this, as you can see here, and exposing these areas. Then there is some echo, I don't know where it's coming from, but you see here, this is the exposure of these areas. And then opening the dura mater here at the area of the Tübingen line. If you can see here, this is the area we used to cut the dura mater. If you follow the anatomy of the petrous bone, you are going to see that in this area, the dura is not very tightly attached to the petrous bone, and all these lines end in a certain point. This line here, this level, will represent the inferior border of the internal auditory canal. So you continue here. The first step is drilling, and afterwards to evacuating the content of the internal auditory canal in order to have a distal control of the cochlear and the facial nerve. So because we usually cannot see directly the fundus of the interauditory canal with a retrosigmoid approach if we are going to preserve hearing and preserve the labyrinth block. So we can use the endoscope to make this directly visualization. Using this technique, we can replace completely the advantage of the middle fossa in terms of directly exposure of the fundus. So endoscopic tool is for this kind of technique very useful. So I would like to show briefly a couple of cases. Initially, a small tumor we did in supine position. First step is to open the system after a linear incision of the dura mater, as I told. So this is the cochlear nerve here and the tumor. Then we cut the dura over the area where the interauditory canal is to be expected. And then we drill away this bone. You see here, we don't trespass this area because otherwise we are going to enter maybe the jugular bulb. Then we open these. I go a little bit faster. So this is the exposure, wide exposure of the interauditory canal. This patient had a high jugular bulb. We had to skeletonize it a little bit. Then we open the dura mater and we start the tumor dissection. So I put here a little bit faster. Tumor is debulked, and then with cavitron, even small tumors can be diminished in size first before we start the dissection of the facial nerve above and of the cochlear nerve below. And then under careful electrophysiological control of auditory evoked potentials and facial MEP, we dissect the tumor from the nerves away. And you see, we irrigate a lot of times with papaverine, as Michel has shown in his lecture. We use the same papaverine solution during surgery. And then, you see this kind of two hands dissection. So with one hand, we hold the tumor. With the other hand, we separate the structures from the tumor surface. And so this way, we can do really a careful dissection without damaging the structures. So at the end, we have removed the tumor totally, but we have to control it. And using the endoscope, you see the high jugular bulb that can be seen here at the CT scan. And then you can see the fundus, transverse crest, facial nerve, cochlear nerve, and another tool, another opportunity the endoscope is giving to us is to detect opened air cells. You see here some opened air cells you will miss under the microscope. And this is one big cause of CSF leakage, as Pierre has shown. So our technique to avoid it is to close directly under endoscope with bone wax, and then we put muscle and fibrin glue. So this is the technique we are using to avoid CSF leakage from the interauditory canal. So another case is a little bit larger one. I have shown this case a couple of times because it's very illustrative. Just a second. Yes, and this is a young patient, a lawyer who wanted to get married, have children. So we discussed all options, radiation or surgery. And of course, she decided for surgery because she want to get pregnant and have children, was very much afraid concerning radiation in her young age. So you see opening the interauditory canal, and then visualization with endoscope. You can see some tumor remnant here that we have to remove. And this was removed. And then I go a little bit forward, you see debulking of the tumor, and then the technique for dissection. You see here with one hand, we hold the arachnoid and the perineurium. We do not touch the nerves itself, and then tumor is removed. The advantage of sitting position is that you have a clear view of the field. We almost don't use bipolar. In my opinion, bipolar is really a poison to the nerve structures. And then finally, again, we close the opened air cells with bone wax and muscle and fibrin glue. Now, a little bit larger case, this patient had good hearing before surgery with a larger tumor. And our goal was here, try to remove everything if it's possible, otherwise to do a subtotal removal and preserve the function. Yes, so I will go a little bit faster. So this is the exposure, sigmoid sinus, and this is a linear incision of the dura mater, you see, and later on we can close it easily. Then we open the cistern. You can see the first structures you can visualize are the lower cranial nerves. And then we don't retract these areas, we just hold the cerebellum. And even in large tumors, we start a dissection with the interauditory canal. We open the interauditory canal and we evacuate as much as possible under careful control of the monitoring. So I go a little bit faster to show you the further steps. Then we make a debulking, and then we can be very comfortable here because within vestibular schwannomas, there is no nerve, there is no vessel, nothing, different than meningiomas. And then after debulking, we can recognize the cochlear nerve. The cochlear nerve is visualized, and then we start the same type of dissection I have demonstrated earlier. You see facial nerve and the cochlear nerve with irrigation using papaverine, and we touch only perineurium and arachnoid. And slowly, slowly, the tumor is dissected. And at the end, we could perform a near total resection. A very thin piece of the tumor remained behind. I can show you, you see here this thin part. This is tumor we have left on the cochlear nerve in order to preserve hearing. And this piece, I operated this patient more than 5 years ago, and nothing has developed so far. So we are lucky. And she had a good balance, could use skin and so on. And finally, this large case, similar strategy, you see, even in this large tumor, the first step is open the interauditory canal using sitting position, again, almost not using bipolar. And I show you similar. So even a bloody tumor, this is the advantage of the sitting position. In these cases, you have even in bloody tumor, you have a not very bad view, and we can dissect the structures away from the tumor capsule. And I go to the end, so you can see at the end, using these debulkings and dissections, we could perform a good removal and with preservation of the last structures. And you see here the accessory nerve and facial nerve, even the vestibular, the cochlear nerve was preserved anatomically, but without function. So, but if the cochlear nerve is preserved and without function, you can try later on a cochlear implant. Some patients want it, some others do not want it. And even in large tumors like these, for neurofibromatosis, mixture of meningiomas and schwannomas, we use the retrosigmoid approach to remove the tumor, and we use the retrosigmoid approach to put ABI. So we can make everything using one single approach. In some cases, we are lucky and we have Haus-Brackmann 1 immediately after surgery, like this case, despite complete removal, like this case, like this other case. But sometimes we have worsening of the results, like Haus-Brackmann 3 or Haus-Brackmann 4. The point is what happens with these cases. You see here, before surgery, almost all patients had Haus-Brackmann 1 and 2. Immediately after surgery, we had a deterioration in more than 50% of the cases. But what we observe is this improvement over time, so that in T1 tumors, all patients regained Haus-Brackmann 1 and 2. In T2 tumors, 99% had Haus-Brackmann 1 and 2, and T3 tumors, 93%, and in T4 tumors, it was 77% of the patients have Haus-Brackmann 1 and 2. Here are some examples. Large tumors, all these patients developed Haus-Brackmann 4 immediately after surgery, but later on, they had very acceptable function, so that I'm not too much afraid to have Haus-Brackmann 4 after surgery. Of course, this is absolutely not pleasant, but if we can achieve a radicality of tumor resection, and later on I have these phases, for me is very acceptable. There are, of course, cases like these. The patient had already facial palsy before surgery. We left tumor behind, clear tumor behind, to keep the remnant facial function. Here, Haus-Brackmann 3. Later on, she developed Haus-Brackmann 2. Or older patients, we can leave even more tumor behind. These tumor can be irradiated later on, but not that tumor. And what happens with the tumor remnant? This is the problem. If we have tumor remnant, in our series, we had 40% regrowth of this subtotally removed tumor in comparison to 6% of totally removed tumor, or gross total tumor removal, and in T4, the same situation. And these results are very comparable to the results published by Nakatomi 2017 in GNS. And finally, hearing preservation is a difficult topic. We know that. In a number of cases, even with preservation of cochlear nerve, we can lose hearing. We have a couple of cases of hearing recovery using a cochlear implant. We are still, and I guess everybody still fighting to get better hearing preservation. These results are not that bad, but we hope we can improve them over time. So Michel has shown his strategy. It looks very good for better hearing preservation. Although the question is what happens with tumor remnants, if they will produce over time, again, hearing loss or not. This is something that we have to wait for the follow-up. Complications in 1000 retrosigmoid approach, we had one mortality. The patient had thrombosis of the sigmoid sinus with bleeding of the cerebellum and a lot of complications. Finally, he died 6 months later. Otherwise, 6 patients needed resurgery because of bleeding within the CP angle, but they recovered. At the beginning of our series, we had 11% CSF leakage. Changing the technique, we're using the endoscope and using bone wax and muscle with fibrin glue, we could reduce these rates to 3%. All of these patients being treated with lumbar drain only. and very rarely we had to reoperate these cases. So this is, in summary, what I want to show to you, and I hope we have a nice discussion very soon. Thank you.
Thank you so much, Marcos, for sharing with us your impressive series and result on vestibular schwannoma surgery. So it's time now to move to the last speaker. Thank you for the first time also to Massimiliano Visocci to join us. Massimiliano will focus on another topic, which is the macrovascular decompression. So please, Massimiliano, up to you.
Thank you so much. Do you hear me?
Yes, perfectly.
Thank you so much for this kind involvement. And it's a big honor to me to share my experience on the microvascular decompression for trigeminal neuralgia. Do you see my slide?
Yes.
Thank you. As a matter of fact, trigeminal neuralgia treatment by microvascular decompression starts from many years in our institution, and our study have been supported both by Italian Society of Neurosurgery, but also World Neurosurgeon Federation of Cranial Nerve Disorders, a very important, huge worldwide society involved in cranial nerve disorders, which was born in China many years ago. And I had the opportunity to share also in some publication what we have learned and also our mistakes. As all we know, cranial neuralgia is a complex and quite difficult word to be understood, including trigeminal neuralgia, Reisberg neuralgia, vagal glossopharyngeal neuralgia, occipital neuralgia, all different in the pathophysiology, but similar sometimes for clinical presentation. As all we know, typical trigeminal neuralgia is associated with trigger point, paroxysmal sensitivity to carbamazepine, absence of hypoesthesia. On the other hand, atypical trigeminal neuralgia more likely to be related to infection, trauma, dysmetabolic syndrome, vascular pathology, and is cramping, burning, long-lasting allodinic neuralgia with the hypoanesthetic area and constant topography. Generally is bilateral in multiple sclerosis, especially young age. As we all know, trigeminal nucleus is three kind of nucleus. The cranial, the more cranial one is a motor nucleus, mesencephalic one. The central one is mainly protopathic, epicritic sensitivity nucleus for proprioceptive perception, and the dissenting root of a trigeminal nerve, mesencephalic and high cervical spinal cord, is much more consistent with the pain transmission. Also, topography is very important to be known in order to orientate when we perform lesional or conservative surgical maneuvers, since there is a rotation of V1, V2, V3, and quite an inversion in the surgical view of the operator who's approaching by an open manner the trigeminal root. The beautiful anatomic pictures that our previous colleagues showed us are impressive in showing how complex is the word at the cerebellopontine angle when we deal both with trigeminal neuralgia and acoustic neurinoma or conflict of the lower cranial nerve. Many other outstanding speakers introduced the concept of a retrosigmoid approach. And first of all, according to the colleagues who presented the tractography and the neuroradiological pattern associated with the preoperative planning in cerebellopontine surgery, MRI examination is first choice, mainly with the contrast medium, but also CAT scan are important in order to better detect calcification, the acoustic meatus, and many other related anatomical landmarks in order to approach at the best the trigeminal root. But let's start with the clinical position. In our institution, we start at the very beginning with the Fukushima position, the same for extreme lateral approach to the cranial vertebral junction. And we found out that this position can produce some problems in venous flow. And nevertheless, it's very simple to be arranged in the operating theater, and also the surgical approach and the wound curvilinear incision are quite simple and minimally invasive to be considered for such a patient. The patient has to be 15 degree in a flexed position with the head rotated 180 degree on the contralateral side in order to expose and better offer to the surgical view the conflict. But as we all know, there are many other positions: the prone position, the concord position, which is a variation of the three-quarter prone position for the cerebellopontine angle, old-fashioned position, and also semi-sitting modified park bench position are considered in our surgical armamentarium. As a matter of fact, park bench position is right now the best preferred in our institution, and it allows a best exposition of a cerebellopontine angle to trigeminal root origin to the surgical view, and also the air inflation and also the venous circulation is better allowed by using also pillows under the axilla and some anesthesiological tip and tricks to ensure a good metabolism and vascular circulation. And as we see here, this is the surgical operating theater, and also the target point, the surgical key point, according to Tatajiba presentation, who called a sternal approach, the pterional approach of posterior cranial fossa. Very interesting and clever definition of this simple but delicate surgical approach. We can identify the angle where to put the drill between the posterior root of zygomatic arc, which is an ideal prolongation of transverse sinus, and the vertical line on the tip of the mastoid. In this angle, there is the asterion, and just close to it or on the asterion, we can perform the burr hole, and then to enlarge with our trephine and perform a circular craniotomy and not craniectomy, as we were used to do in the past. Very important is the optic assessment with the microscope, sometimes with the magnificating glasses or endoscope. We will see at the end of this presentation. But mainly the main actor of this complex surgery and assistance is the neurophysiological monitoring and assistance, which is performed in our institution both by medical doctors and also a specialized technician. Three topics are the main point of this surgical planning: positioning, and we have spoken about it, the possible CSF drainage, or just the intraoperative CSF sucking in order to better expose the angle and also allow to the cerebellum to be flattened according to the necessity of the surgeon. And the third topic is what to do, craniectomy or craniotomy. As I was introducing a few seconds ago, we prefer to perform a craniotomy, a circular craniotomy, after plugging the emissary vein, which is external reference points of the internal dural sinus. We perform a circular, a quarter of dollars diameter circular craniotomy with our trephine, surgical trephine, close and facing with the transverse and the sigmoid sinus, and we can open with different manner the dura, like Y shape, or also linear or semi-linear shape manner, in order to better tailor both opening and closure of the wound and avoid as much as possible post-operative CSF leakage, according to the beautiful presentation of the speaker, the very beginning of this beautiful webinar. We all know and are familiar with this special anatomy, with the dandy vein. Someone says to open it, to close, to cut it, 100% of the cases. I remember that many occasions Tata Jiba state that he tried to preserve it as much as possible. Different way, different strategies. I operated at the very beginning of my career many cases by cutting the dandy vein without any complication, but in one case among 100. But right now I try to preserve it as much as possible, since venous circulation is strategic in this complex and intricate local anatomy. And as we can see, we can deal with the fourth nerve, the third nerve, or close to the five nerve, and any vascular damage close to this intricate, wood anatomy can result in postoperative undesired dysfunction, permanent or transient. But let's see some special case. This is a lady who underwent to radiosurgery for a typical trigeminal neuralgia some years before a recurrence of a typical left-sided trigeminal neuralgia, and we opened according to the surgical principles which were exposed a few slides ago, and this is what we have found in this case. As you can see, very important is to suspend the dura, but also to withdraw the CSF and try by opening the cisterns at the base of the cerebellum as well as at the cerebellopontine angle to deflate and to manipulate as much as possible in a safe way and manner the cerebellar hemisphere. But as you can see here, the arachnoid has a very gray appearance, and it shows the effect of radio surgery. But despite our expectations, the CSF drainage as a consequence of arachnoid opening is quite safe, sure, fast, without many important hemorrhage, and we proceed by debriding the trigeminal root, which appears without any X-rays related wound effect. We just try to decompress by arachnoid adherences the root. I insist the root is quite normal one. Otherwise, arachnoid surrounding the root is very compromised. The dandy vein is preserved, and according to our strategies, we put around the root a pillow of inert material, and try to protect with a Teflon from the ICA pulsation the root. And then we proceed with the classic traditional way to fill and protect 360-degree the root by preserving in our new strategy the dandy vein. And we put back the bone with some plates and skew, titanium plates and skew. But which is the news? Is it really news, but maybe a revival? The endoscope in cerebellopontine surgery probably is the both, because at the beginning of the 70s there was a big deal of interest on the use of endoscope to system surgery and complex cerebellopontine angle surgery. But at that time, the technology was not enough to ensure a complex control, 30-degree, 45-degree control of this local complex anatomy. But the seed was put in the ground, and in some years, the attention and the inspiration to take advantage of endoscopy in this cerebellopontine surgery rise up again, and now endoscopy and microsurgery both are an important option in microvascular decompression for a typical trigeminal neuralgia. And as you can see here, this is a typical endoscopic surgical theater with both the opportunity microscope and endoscope with the 4K visual opportunity. And this is one of our very first use of endoscopy when we were used to perform a craniectomy, but in this theater you can see how useful is the endoscope to deep in a very effective way in the local complex anatomy by preserving the dandy vein and also by peeling the trigeminal root. And in this case, we performed a neurectomy because of the special nature of the symptomatology. And this is another surgical options. But many pictures, and I'm concluding right now, are available with the endoscopic tool, different anatomy from the one we are used with the classic microscope. And the endoscope allows to control after the compression if some vascular loops are still effective in compressing and offending the nerve, and allows us to better complete our dissection and trigeminal root presentation, as well as filling the cistern with inert material like Teflon. And endoscopy is the future, in my opinion, of such a challenging surgery, but please don't forget that we have to tailor our knowledge, our surgical tools, our knowledge to the specific reality of our patients. So the patient first, and then what we prefer to use as a technical tool. Thank you so much for your attention.
Thank you, Massimiliano, for sharing with us so many tips and tricks to improve the results. I have not yet had the chance to present. Can you stop to share your screen, Massimiliano?
Yes, I'm trying. Just a second.
To present Casper Eckhardt, who would join us in the panelist to enter the discussion. I think, Eck, that we have had a wonderful webinar in order to improve how to manage such difficult lesions. We can decrease the morbidity from the preoperative planning to the closure, and we have had the chance to see wonderful results for vestibular schwannoma surgery, all the tips and tricks that were shared with us also for microvascular decompression in order to improve the results. There are plenty of questions. Maybe, Ek, if you have one special comment after all those wonderful talks. There are questions that were answered in the chat box, but maybe, Eckhard, would you like to make a comment and give also your input into the discussion, please? You are just muted.
For having me. I just wanted to congratulate the last speaker. I think Massimiliano explicitly said at the end, it's all about the patient in front of us, and we need to optimize the approach as well as the tools that we use to get the best. And I think if we can take this away from today's seminar, that's for me already a very important teaching point. You want to optimize every aspect of your surgery and every step on the way based on the local anatomy that you find in the one patient in front of you. So pre-surgical imaging for me is one of the most important aspects of planning the right surgery, to get the positioning right, to get your thoughts right, how you would like to approach a large vestibular schwannoma, how to avoid complications. I think it's all, the mindset from the very beginning of the case, and then using endoscopy as an additional tool to be able to inspect your resection cavity locally to understand, is there maybe something I didn't see well through the microscope, as was said, is excellent as a teaching point for today's seminar. I really just want to start with that.
Thank you, Eric. Is there any question of one of you?
There was a question from the audience about the possibility of vascular complication in cerebropontine angle surgery, and I think that we should focalize our attention to the possibility of sigmoid sinus thrombosis in cerebral pontine angle, because we didn't speak about in this wonderful seminar, but it is an undesired and quite mysterious complication of our surgery. Why we face sometime 1% of our cases, why we face with this complication, and according to the hematologist, the anticoagulant therapy is not indicated because this thrombosis, they states, is transient and quite safe one. But when we retrospectively examine our surgery, also by video, we do not find any strange movement or compression to the transverse sinus to justify such a finding. So to me, it remains a mystery. What is your explanation, interpretation of this unusual but possible complication?
Yes, indeed, it's something that can happen. And I hypothesize at some point that it is the eating source of the microscope that could induce some kind of thrombosis. And so protecting with cotton pads, water, and also maybe the retraction of the dura, tracting a little on the sinus. Maybe Marcos or the other, if other explanations about that?
I think the easiest explanation is any kind of injury to the sinus. So not the microscope. We should not put the cause to the microscope. I must say I'm not present in all craniotomy procedures because this is done by the residents. And you may have injury of coagulation of the emissary vein. So you find the emissary vein in almost all cases. And how to deal with emissary vein is very important. And another point is, if there is any bleeding of the sinus, the resident should never put gel foam in that area because it's highly thrombogenic. So if there is any injury to the wall of the sinus, what I do is I put a piece of muscle, not inside, but covering. I create a new wall with muscle and fibrin glue surrounding that. And then after surgery, we do a CT phlebography in order to see how the sinus is doing. And if the patient has no bleeding within the head, we start early with low dose heparin. Because, you know, a bleeding you can remove. Thrombosis of the sinus, you are lost. I lost one patient because of thrombosis of the sigmoid sinus. It was the only case we lost in this series. It was a dominant sinus and no chance. We had cerebellar edema, bleeding, and everything was congested. So in my opinion, it's a very, very important topic. And when we had a webinar on complications in neurosurgery organized by Keke Turel, this point has been pretty much discussed. But this is a point we could discuss in another webinar from the EANS.
For sure, it is planned on the complications. But it's sometimes impressive to see under the microscope what is the heat. If the light is very high, the heat under the light is very impressive. So I will also be careful on that point.
Yes,
I agree with both of you. I think that the sum of many factors, each one insufficient to drive it by itself, this complication, but all of them together probably enough to produce and promote thrombosis must be claimed. I think that also dura suspension with the switches and some weight We use Clemmer, Cocker, you know, and if you try to evaluate how is heavy this piece of metal on a very small triangular, you know, flap close to the dura sinus, probably we can understand how functional hypoperfusion can produce and how functional venous stenosis can produce. And so I don't know many complex factors, but a true reality to be better investigated.
Yeah. And the use of bipolar on the wall. You saw sometimes you have some bleeding and put bipolar on the wall. In my opinion, this is even more dangerous than the heating of a microscope.
We are already late. There are also one question about the lumbar drainage. If you can give your opinion on the place of lumbar drainage in huge tumor. I have my answer, but I would like to hear yours.
I never use it. I use only if there is CSF leakage.
At the very beginning of our surgical activity, we were used to put 100% lumbar drainage before opening. And as soon as we opened the dura, the lumbar drainage was activated. But right now, starting from many years, we stopped to put the drainage, and we orientated our surgery to find as soon as possible the ambient cisterna and to open it and to suck and drain CSF from the very beginning at the base of the cerebellum and then at the cerebellopontine angle, and so to make more mobile and smooth the surgical manipulation.
I think unless there is another comment, we all agree on that. So I would like to congratulate you for all your wonderful talks. I think we had a very great webinar. It's time now to leave you, and we will have the opportunity to be again together in 1 month on another topic. It was a pleasure for me, and I would like to send you my best wishes for the end of the year and the coming new year. So it was the last time this year that we are together, and it will be my pleasure to meet you at the beginning of January for our next future projects. Okay.
Merry Christmas. Happy New Year.
Bye-bye to all of you, and see you next time. Bye-bye, my friends.
Thank you very much. See you. Bye.
Thank you, Mike.
Bye-bye. Avec plaisir, Pierrick. Bye.